Thank you very much, Dr. Sultan, for your kind introduction. And I'd like to thank Vertex for this opportunity and thank SSBMT and SSH for the invitation. So I'm going to talk to you today about gene therapy, a new era in hemoglobinopathies. So what we'll discuss today is the incidence of sickle cell disease worldwide, gene therapy history, and gene therapy trials results. So worldwide, we get about 500,000 child a year affected by sickle cell disease. And as you can see here, the countries in orangey color, and the darker the orange, the more the incidence of sickle cell disease in these countries. And you can see here the specific mortality from sickle cell disease. As the country is more advanced, then the death rate is reduced and the country color becomes light blue, despite the higher incidence. And you can see Saudi Arabia here, although the incidence is high, but the mortality from the disease is lower than African countries. This is the incidence of death under the age of 5 years from sickle cell disease, and I can see that the countries who are affected by this in terms of ranking. And the cause-specific death from sickle cell disease, patients who are affected by sickle cell disease, they don't do as well as the general population, as you can see here. This is the sickle cell mortality between 15 to 49. Again, the mortality in this point in time is increased due to sickle cell disease. So, history of gene therapy in 1987, Atsu Nakata group in Japan, they described this CRISPR finding in Escherichia coli. It's the P stands for palindromic, and palindromic means it can be read from left to right and right to left the same way, just the same as the statement like race car. You can read race car from left to right and right to left. So these are repeats inside the Escherichia coli that help the Escherichia coli detect retrovirus when they enter it. So it's part of the immune system of bacteria, and it helps bacteria fight viruses. So this is CRISPR. The Cas is an enzyme. It's a nuclease in Streptococcus pyogenes. And when it is bound to the technology of identifying areas that are palindromic, it gives us gene editing ability. So this is the Cas9, which helps bacteria fight retroviruses. It cuts DNA as it finds the CRISPR, the palindromic areas in the virus DNA, and kills the virus. These two ladies, Donna and Carpentier, they got the Nobel Prize in 2020 because they transformed the technology which was found and described in the bacteria into cell lines in vitro. And this CRISPR-Cas technology has a wide variety of applications, not only in gene therapy, but also in biofuels, ethical concerns, disease-resistant cancer. In the future, it will be also applied in cancer therapies. So in the CRISPR technology, the first point in editing a gene is to identify the area that is palindromic. And this is done by a guide RNA. This is synthesized in the lab, and it guides the CRISPR-Cas nuclease into this area. And what we do is we collect the stem cells from the patients, and then the cells are taken to the lab, and in the lab the stem cells are electrocuted, so it have pores in the cells, and these pores through which the CRISPR-Cas nuclease enters the stem cells. And for this reason, because some of the cells actually die from the electrical currents, for this reason why this technology requires a lot more stem cells than any other autologous or allogeneic stem cell transplant we do. And as the CRISPR-Cas technology enters the cell, it identifies the area that it binds to it, and then it targets the gene that we want to edit. We find the gene that needs to be edited, and it either deletes or modifies or adds a gene. So there are many other editing technologies. CRISPR-Cas is one of them. There is the TALENs and the Zinger finger nucleases, and all are the other two, the TALENs and Zinger finger, is a DNA technology, while the CRISPR-Cas is a DNA-guided technology. So this is one of the differences. The RNA sequencing is important in the CRISPR-Cas technology. It uses the Cas9 enzyme, while the other two technologies use the focal nuclease. The difference between CRISPR-Cas and the other technologies is very easy to use, while the others are more moderate to difficult. The Zinger finger nuclease was the first to be discovered, and I think now it's become historical. The cost is lower with CRISPR-Cas, and the editing efficiency is higher with CRISPR-Cas, and the off-target risk is moderate. So multiplex editing is easier, but it's rapidly expanding the CRISPR-Cas technology. There are other technologies being processed at the moment, and you can see this in the list. Some of them use permanent technologies to edit the genes permanently, some don't. And we will see more of these technologies of editing genes in the future. So we'll go to the trial results, the CLIMB 121 and 131 of exa-cel. And basically here, the CRISPR-Cas is used to edit a gene called BCL11A, which inhibits hemoglobin F. And as you delete this gene, then the hemoglobin F is started to be produced more because this gene inhibits hemoglobin F production. So we've discussed this. We screen the patients, we collect the stem cells, then after the stem cells are dealt with, the patients are conditioned, and then the exa-cel is infused, and then follow-up for 2 years is the CLIMB 121 trial, and after 2 years it was called a CLIMB 131 trial. And we will see the results of both trials. So the age was about 21, 46 patients were enrolled in this trial. The majority were actually 18 to less than 35. The majority were hemoglobin SS disease, 90% of the patients, and very few patients had one gene deletion of alpha gene. There are very few of 2 gene and triple gene deletions enrolled in this trial. So the engraftment was about 1 month of neutrophils and about 1 month for platelets. The CLIMB 121 primary endpoint was freedom from painful crisis, vaso-occlusive crisis, and freedom from hospitalization. And at 1 year, 91% of patients were free from vaso-occlusive crisis, and 98% were free from hospitalization. This is a swimmer's plot which shows the patients in gray are the patients before they get the treatment, and each line is one patient, and the red bars are the transfusions they had, and then the dots in the green line tells us whether the patient had vaso-occlusive crisis after the therapy or not. And you can see the majority of patients didn't have any vaso-occlusive crisis after the therapy. The one I marked here in red is one of the few patients who had multiple vaso-occlusive crises after the gene therapy. In the older group and in the younger group, only one patient that had multiple vaso-occlusive crises. The rest, as you can see, there aren't any dots in their lines. The hospitalization was even better, and so very few patients, even if they had vaso-occlusive crisis, they were not admitted. It was mild vaso-occlusive crisis, and the majority of patients were not hospitalized after the therapy. This is the level of hemoglobin F, and you can see here the hemoglobin has improved after the treatment, and the hemoglobin F reached about 45 to 50% in the majority of patients. So half the hemoglobin became hemoglobin F. This is a bone marrow showing the percentage of patients with edited cells, and you can see here that 70 to 80% of the patients have actually edited cells. The hemolysis markers, the LDH, haptoglobin, reticulocyte count, indirect hemoglobin, all improved after the therapy. So this is the quality of life of patients after the therapy, and you can see, compared to the US population, the quality of life of the patient in this trial has improved, and it's equivalent to the US population or maybe slightly better. The toxicity is related to the busulfan, which we expect because it's like an autologous transplant, and the mortality was about 1 patient died, which is about 2.2% of the patients. So this trial concluded that 91 achieved freedom from vaso-occlusive crisis, 98% from hospitalization, 100% were actually free from hospitalization of vaso-occlusive crisis at the latest follow-up at 3 years. So at 3 years, everyone was free from vaso-occlusive crisis and hospitalization. It's durable. Hemoglobin F is about 40% or more, stable editing, and results were consistent along the age groups. Adolescents required few mobilization cycles, which is an issue sometimes, and safety profile is consistent with myeloablative busulfan, and long-term follow-up is needed to see if there is a functional cure for these severely affected patients. This is a thalassemia patients where the same gene is being edited, and again the age is about 21 years, and it's hemoglobin beta 0, and beta 0, beta-like, the majority of the patients. Iron overload, the median iron ferritin level was about more than 1,200. And this is important. Neutrophil engraftment, again, same like 1 month. And again, this swimmer plot shows the patients who require blood transfusion after the transfusion of the cells. And you can see the majority of patients actually don't need transfusion, while very few patients needed transfusion after the infusion of the cells. The majority of the patients actually had green lines. The hemoglobin F here was much higher than in sickle patients, and you can see here hemoglobin F was about 11 grams. And the bone marrow, again, maintained the allelic ratio. There is no death in this part of the study in thalassemia patients. Patients on iron chelation had to stop iron chelation before the infusion for about a week. And then after the cells are infused, they are not allowed to start iron chelation for at least 6 months after the infusion. And then they looked at their iron levels, and you can see here 69% of patients after 6 months they restarted their therapy, and 70% are without any iron overload. This is their serum ferritin improved, and this is their liver iron, again improved after the trial. And this is their erythroferron and hepcidin levels, again, they're all improved. So concluded that after follow-up of 6.5 years, 95% of participants achieved the primary target of freedom from transfusion at 12 months after the infusion of the cells. 98% of the patients are free from transfusion at 3.9 years after the end of therapy, and it's durable increase in hemoglobin F and stable allelic ratios. So exa-cel is potentially correcting the ineffective erythropoiesis in sickle cell. 70% of patients do not require long-term iron chelation after the infusion, and there is no evidence of reaccumulation of iron in these patients. The safety is consistent with someone receiving busulfan conditioning. The long-term follow-up continues to demonstrate exa-cel has the potential to provide one-time functional cure to patients with TDT. The next gene type of treatment is the gene addition trials. The gene addition trials, the lovo-cel. The lovo-cel is used for sickle cell patients. It is similar to exa-cel. You need to use busulfan, but here you edit the gene. So you delete the gene that's causing sickle cell, and with a lentivirus, you introduce a gene that can produce normal hemoglobin A. So encoding beta hemoglobin A, it's called beta 87Q. And the process is similar. You collect the cells, you use the lentivirus to introduce the new gene that edits the sickle gene, and then you treat the patient with busulfan, and then you infuse the cells that have been edited. In this trial, there are 3 groups. Group A was an exploratory trial where they did the harvest, doing bone marrow harvest, and they used a lower dose of busulfan, and the targeted total amount of CD34 cells was about 1.5. The group B, they did as well bone marrow harvest, but here the busulfan dose was increased, and they used more CD34 cells for infusion. Group B, they did bone marrow harvest and plexifor apheresis, and again, they did conditioning with busulfan at a higher level, and the stem cell dose was 2 × 10⁶ per kilogram. So the outcome, as you can see here, these are single patients. There isn't results for all the patients tried. And you can see here improvement in the patients' hemoglobins and sickle cell crisis. They looked at this in blood abstract in 2023, and they've shown that the hemoglobin A in these patients increased from being 0 to about 40 to 50%, and the quality of life has improved using this gene therapy. Here again, another swimmer's plot showing those patients who actually had a crisis after the infusion of the edited cells, and you can see that the red dots, the majority of patients actually had improvement and didn't have any vaso-occlusive crisis. These are other trials of gene editing that are ongoing at the moment, and they all use busulfan, some use melphalan as conditioning regimen, but we don't have any results of these. There are other editing trials, like this other trial, again using BCL11A locus, and we are awaiting the results of this trial, but this trial uses the Zinger finger nuclease editing rather than CRISPR-Cas9. So in summary, these gene therapies are effective in erythropoiesis and maintaining erythropoiesis. They mitigate downstream complications, including vaso-occlusive crisis, hemolysis, and end organ damage. They are transformative as one-time intervention, and they produce a good quality of life. And you don't need a donor to treat patients. You can treat them with their own stem cells. Complications like graft-versus-host disease are prevented, are not part of complications of this intervention. So the difference between gene addition and gene editing is that gene addition, you get material from other source, while editing, you use the patient's own DNA to edit. Here in the addition, you need a virus to introduce the gene, while in editing, you use electroporation to introduce the enzyme inside the cells. The gene addition is less precise, while the editing is highly precise. So which patient qualify for modifying therapies like the gene therapy that we discussed? So why are sickle patients different? Hemoglobin F level is something that affects the severity of the disease. Alpha thalassemia traits, again, modulate sickle cell anemia. It reduces intracellular concentration of hemoglobin S that in turn decreases hemoglobin S polymers and induces cellular damage, which ameliorates hemolysis. So the amount of alpha thalassemia genetic mutation helps to reduce the risk of sickle cell crisis. So that's why we have different diseases or different sickle cell clinical findings. Some patients get pain, some patients get stroke, some patients get retinopathy, some patients get renal disease based on their genetics and based on many factors, including the alpha gene mutations. So the principal haplotype includes of sickle cell the Arabian Indian type, and it is suggested that this type is, and the Senegalese type have higher hemoglobin F, and that's why they are milder disease, in contrast to the sickle cell originating from Benin, Cameroon, and Central Africa, which has lower hemoglobin F %. And however, this does not reflect true in real practice. There are still patients with Arabian Indian type who have severe disease. We need in the future to know which patient will develop stroke, which patient will develop acute chest crisis, and there is a lot of work at looking at genetics that are involved, may be involved with the presence of S that might lead to complications like stroke and chest crisis. But until this moment, we don't have clear genetic changes that tells us which patients are going to have severe phenotype. So who should we refer for stem cell transplant or gene therapy? The referral pathway, there is no clear-cut consensus. Continued evolution of overall improvement in care for children and sickle cell disease. There is increased number of curative therapies in 2020s, in addition to hydroxyurea. However, the median lifespan of a sickle cell patient still remains at 48, even in the best health care systems. So how to consider referring a patient for gene therapy or stem cell transplant will depend on our clinical judgment and the type of disease the patient has. So who should we choose to refer, and who has the higher risk of dying from disease versus dying from toxicity from the proposed treatment? There isn't any phase 3 trial that randomizes the two types of patients, more intensive versus standard of care, and that's why we have to depend on our clinical judgment. So thus we need our clinical skills in determining the patient most likely to benefit from more intense therapy. And this American guideline published in 2021 helps us to identify some of the patients that might benefit from more toxic therapies like stem cell transplant and gene therapy. So they made their recommendation into strong recommendation, whereby there is enough evidence to recommend a treatment, and conditional recommendation when there isn't very strong evidence, but there is some evidence. So stroke, the ASH guidelines say that HLA match sibling rather than standard care hydroxyurea in patients who have sickle cell disease, who have an overt stroke, or have an abnormal transdoppler ultrasound in children. This is a conditional recommendation for stem cell transplantation, preferably in patients who are less than 16 years. Recommendation 2 is for patients with pain while compliant on medications. For these patients, if they have frequent pains, then this is a conditional recommendation for stem cell transplantation. This is defined as more than two painful crises in the last 2 years. So the potential of benefiting from match-related allogeneic bone marrow transplant varies from small to moderate, and acute pain post-transplant was found to be low to non-existent after transplantation. And this is a beneficial, and maybe having multiple painful crises is a marker of severity of disease, and maybe these patients actually will have a problem in the future with other organs damage. So hydroxyurea can be used in patients who have less crisis, new targeted therapies, chronic transfusion therapies, and patient deemed to be compliant. Conclusion of recommendation 2, its benefit versus harm. The overall certainty of evidence is low. However, if patients have a recurrent crisis, it might be a marker of severe sickle cell disease, and they recommend for stem cell transplantation. Acute chest crisis, for patients with recurrent episodes of acute chest crisis, the ASH recommendation suggests allogeneic bone marrow transplantation, condition recommendation, with very low certainty. It's preferable to do it at an earlier age rather than an older age, as we will see. Why is that? That's again a conditional recommendation. Optimal hemoglobinopathy clinic setup is preferable if you have high incidence of sickle in the community, because in these types of clinic you can risk stratify patients into severe patients, presence of multidisciplinary team in the clinic, and an update of clinical guidelines. And if you have clear guidelines, you can refer patients earlier when you discover they have severe disease, timely exclusion of required investigations, and early referral to referral centers. So safety of stem cell transplantation. The data suggests that large retrospective analysis of sickle cell, the mortality from transplant is about 5 to 20%. And the probability of overall survival in those who are less than 16 years, overall survival of 95%, event-free survival of 93%. However, patients above 16, the overall survival drops to 81% and event-free survival to 77%. And in CABMTR, they shown that patients above the age of 13 with myeloablative conditioning, they don't do very well with transplant. So patients less than 16 years of age, acute GVHD is 12%, chronic GVHD is 14%. When you go above 16, the GVH increases to 16 to 23%. Graft failure incidence, again, is about 5 to 10% in match-related donor patients, which is a risk with allogeneic transplant. Infection risk is, again, a risk with allogeneic bone marrow transplants. And infertility is another risk for referral to allogeneic bone marrow transplants. Secondary malignancies in the long term is, again, a risk for allogeneic bone marrow transplants. And some centers use myeloablative therapy. However, this is median age is younger group. This is mainly pediatric patients. And overall survival is very good, 94 to 100%. However, the graft rejection is about 2 to 10%, and chronic graft versus D about 12 to 20%. And transplant-related mortality can be high if you use myeloablative. And you can see here in this specific study, the mortality was 13%. So reduced intensity, again, very good survival. However, graft rejection is a bit higher in this group. However, chronic graft versus host disease and TRM is less. At our center, we use less intensity treatment. So stroke or clinically significant neurologic deficit lasting more than 24 months is an indication. 2 or more episodes of acute chest crisis is an indication. And 2 or more vaso-occlusive crisis in 2 years is an indication. And tricuspid regurgitation of velocity of more than 2.7 in an echo is another indication. And regular blood transfusions, more than 8 transfusions per year for more than a year is another indication for referral. Some consideration for case-by-case, cardiac dysfunction and tricuspid regurgitation, dystolic dysfunction, confirmed by right heart catheterization, lung disease or progressive lung disease is another indication that needs case-by-case discussion, progressive kidney disease, major priapism and early bone disease. And AVNs, again, is considered as an indication in certain cases. Early liver disease and chronic blood transfusion complications. We all know alloimmunization. So patients who are receiving multiple blood transfusion over a long period will develop alloimmunization, and this is very important that we avoid that. So excluded from referral is left ventricular ejection fraction less than 45, carbon monoxide diffusion less than 50, estimated GFR less than 30, and sickle cell related
1 minute, Doctor.
Hepatopathy is another indication. So liver fibrosis. So gene therapy, the trial included patients 12 to 16, but they didn't have any CNS problems or less than 150 centimeters per second. And they had 2 vaso-occlusive crises per year, and they were sickle cell disease. So, and they had good echo status. Exclusion criteria was patients who did not have So there included patients who did not have HLA-matched siblings, and patients who had autoimmunization and did not have blood available were excluded from the gene therapy trials. They excluded patients with renal impairment and poor lung function and lower ejection fraction. So I will conclude my study. There is a certainly benefit for gene therapy over transplant in terms of neutrophil engraftment, in terms of transplant-related mortality is much less. Graft failure is non-existent in gene therapy, and acute GVHD is also non-existent. And finally, we have to use our clinical sense and the clinical phenotype and treatment to identify patients who actually qualify for allogeneic stem cell transplant and gene therapy. And thank you very much.